I'm presenting the webinar today. Yeah. How about yourself? You're joining as a participant, or you're?
Yeah.
She's joining as a participant. Okay,
yeah.
Great. Okay. Nice to have you today. Thank you for joining today.
Thank you. Thank you very much.
Okay, shall we start?
Sangeeta, my voice is okay?
Yeah.
Yeah, great. Yeah, thank you.
Yeah.
Has it started?
Yeah.
Okay, shall I start then?
Yeah.
Okay, great. Okay. Hello, everyone. Welcome to our second webinar in honor of the Pulmonary Rehab Week. And today's topic is more oxygen and more muscle. And I'm just going to jump on to my following slides. So thank you. And this goes without mention to the mentoring community, making this as a possible event today as well. And a disclaimer, this presentation is not a medical advice, but an information to create awareness of pulmonary rehabilitation. And any information or the approach should be used in discussion with your current provider. And the author or the mentoring make no warranty or representation that these considerations will improve your health or prevent possibility of the negative outcomes. And this presentation is prepared based on the information available at the time of writing and can be superseded by the latest developments in the field of pulmonary rehabilitation or the oxygen therapy. And hello and welcome again. And today's topic is more oxygen and more muscle. So I would like to my best of knowledge, raise awareness on the oxygen for people with chronic respiratory disease, and to clarify an air between the terms of hypoxia and hypoxemia for people with chronic respiratory disease, and to discuss the current practices and challenges on oxygen prescription for people with chronic respiratory disease, and to discuss some myths around supplemental oxygen. So I'm keeping this as a 4 objective today, and hopefully we will actually reach the end with a smile on our face. So who am I to discuss today all these points related to a medical oxygen prescription and discuss more about the pulmonary rehab settings? So I have experience of about 20 years in physiotherapy and specialized in pulmonary rehabilitation for over 9 years in Dublin as a pulmonary rehab coordinator and a senior respiratory physiotherapist in Dunleary in Ireland. And prior to that, I was also a senior physiotherapist in primary care in healthcare services in Ireland. And I moved on to Lancashire Teaching Hospital and worked as a clinical lead in home oxygen for 22 months. And later on, I had an opportunity to be a lecturer in cardiorespiratory physiotherapy in Cardiff University. And I moved from Lancashire to Cardiff in 2018. I also have 15 years of experience, post-qualified as a counselor and psychotherapist, using motivational interviewing and cognitive behavioral therapy for patient recruitment and prescription. I had a small role in clinical research and perspective papers since the year of 2009 until 2021. I hope so. I filled in a lot about me, and I will leave it to you. If you are interested more to know about my professional career, you can visit the link in the LinkedIn profile. Without any further ado, I would take you to the following slides. So, breath is life. We are aware of without oxygen, we cannot live. Why? Because oxygen is very important and crucial for all the functions inside our body and to our functional activity in the daily lives. So I put on as a representation of what happens in terms of the gas exchange process inside our lungs. When we breathe in the oxygen, we are not only breathing in oxygen, we are also breathing in a lot of other gases into our nose. And those gases, major part of the portion of the gas is oxygen, and enters into our nasal pathways and through our air trachea, enters into branches into bronchi and enters into the lung. And inside the lung, you can see this picture here, there is a lot of small air sacs, more than 300 million, in our lungs. Okay, we have two lungs, as you're aware, and each of the lungs has millions of air sacs. And these air sacs are the end point or destination where the oxygen, what we breathe in, enters. And each of this particular picture illustrates very clearly each of that small sacs is covered with, wrapped up with the artery and the vein. Okay, so whichever is in the red is actually oxygenated blood, which has more of oxygen with the attached to your blood cells, red blood cells, and the blue part represents the carbon dioxide, deoxygenated blood. This is how the gas exchange happens. So our lung is a station where the body which produces the deoxygenated blood is sent back to the heart, and from the heart to the lungs, and then we breathe out the deoxygenated carbon dioxide part of it out into the air, and then absorb in the oxygen inside our body. So that's the normal process which happens. And why we need oxygen? We need, for every vital functioning of our living, oxygen is very crucial, and also for our muscles. So all our functions happens depending on our moving, our walking, our running, our breathing process. Every actions, functioning actions require the muscular contraction, and we need a strength of bulk of muscles to perform those activity as well. So we have different types of muscle groups in our body, as I mentioned in this slide here. Type 1, which is a slow twitch fibers, and it is actually a long distance endurance muscle fiber, and it works at a low fatigue rate. It doesn't get easily fatigued. And type 2A is a fast twitch muscles, and it has a moderate distance and intensity, and it has a moderate fatigue rate. And type 2B is a fast twitch glycolytic muscle fiber, and it gets very quickly tired. So these are the three major types of muscle fibers in our body. And the oxygen which enters in our body actually works up with the metabolic process, which is more scientific. I'm very well aware this is watched by a diverse group of people, and I don't want to go into deep into the scientific details. What happens is, as a result of metabolism and ATP, which is a catalyst which is responsible in the presence of the oxygen for aerobic respiration, and with no oxygen that enters into lactic acid. Lactic acid is a product which causes pain and fatigue. If you have more of pain and fatigue, your muscles have lack of oxygen and end up enacting more of lactic acid production in your bloodstream. And that's how you, after a running or a heavy intensity activity, your legs or your extremities get fatigued and you have a pain. So that's the reason. But in normal healthy population, that gets resolved within 2 days maximum, and with all the rest and ice packs. And that's because your body then functions and you are getting back into normal routine. But for people with compromised lungs, that is actually not an easy task, and your body struggles for it. Okay, so that's why we need more oxygen to have more muscle action and more muscle strength. And it also, oxygen is very essential for the mitochondrial changes, which is responsible for bulking up the muscle fibers. So more amount of muscle fibers will be formed. So these are the main role of oxygen for our muscle, and that's very crucial. So as a result of the compromised lung, we have breathlessness symptoms in our chronic respiratory disease people. And as a result of breathlessness, what's happening is people with breathing difficulties have increased work with breathing, and they tend to use all the accessory muscles. The accessory muscles, what we term as, is a muscle which is actually around, which is not the main muscle, but the muscles which is around our collarbones. Okay, to put it in a layman verse term, that those muscles are getting more hypertensed and more into actions to help the rib cage to expand more, because the lung is struggling for air. So when you're breathless, you see your collarbones being fixed very high, heavily. That indicates that you're very breathless and your lung is struggling. And also in the population of chronic obstructive pulmonary disease, there is a group of people who have emphysema. And emphysema has a high amount of air trapping in their lungs. As a result, there is a dynamic hyperinflation. What I mean by that is, when you're resting, your hyperinflation is fine, like the air trapping is there, but you can manage it in resting position. But when you're starting to walk from maybe from your kitchen to your supermarket, which is just 10 minutes away from your house, you tend to gasp for breath. That is dynamic hyperinflation. So breathlessness is one of the factor where the breathing is interlinked with the thinking process. When these are the factors displaying when you're breathless, what happens to your thinking process? You get panicked, you get anxiety, you get the misconception, and sometimes to the extreme, some people have thoughts of dying. Okay, so that is actually very dangerous, and that's the other part which I'll be discussing in the following slides. But that is a dangerous thinking process. So what happens when you're having that kind of thinking process? Automatically, you stop doing whatever you're doing. You stop doing your functional activities, and you self-isolate yourself. And as a result, all the muscles are again deconditioned. So in chronic obstructive pulmonary disease, there is a basket of disease, I would call this as. It has chronic bronchitis, emphysema, which I already described, and some forms of asthma. So in chronic bronchitis, the main physiology, what is happening inside, we term as scientific physiology, but what really happens is what we are trying to say. So what really happens is your airways, as described in this picture, the airways here, you can see that it has been inflamed and narrowed down. I'm not sure whether everyone can see that, but the picture is very hard to see, but as much as possible, I managed to point with a pointer here. So you can see that the narrowing because of the inflammation. And then these air sacs are then narrowed down as well in emphysema condition. So as a result, there is an air trapping and struggle for breathing. And two major symptoms, primary and more common symptoms, what people with chronic obstructive pulmonary disease have is breathlessness and cough. And other condition which can be included in the chronic respiratory disease is the most common condition I'm talking today. There are other list of conditions, but I'm just focusing on these two major conditions. The other condition is pulmonary fibrosis. So what is pulmonary fibrosis? As you can see that I've explained that there is small air sacs here. These air sacs, if you could closely have a look at that, you see that each of the air sac has coming in the part where the artery is coming in contact with the air sac is called as interstitium, or you can imagine as a coffee filter. Okay, and that coffee filter acts as a porous membrane where your oxygen goes in when you breathe in and spits out the carbon dioxide into the airways, and the airways then spit out through your nose as a breathing out. Okay, so this particular space is very much thickened here. Okay, that is scarring happening in pulmonary fibrosis. That is a condition where, because of the scarring, the layer, which is a coffee filter, becomes like a brick. It has no further movements of the oxygen or the carbon dioxide in and out of the air sacs. So that particular area of the lungs have been deprived with oxygen, and there is a buildup of carbon dioxide. So there is a damage to the interstitial space, and there is a mismatch of the gas exchange happening in pulmonary fibrosis. As a result, patients have breathlessness. So COPD, which I'm going to focus mainly today, is a very serious condition or illness, which you can term as. And what the data says, the British Lung Foundation, as the numbers here, as you can see in the slide, 1.3 million people in UK have been diagnosed with COPD. And it is the second most common in UK lung disease after asthma. And it's 4.5% of people over 40 live with diagnosed COPD. And it is the second most common after lung cancer, main, and it kills around 30,000 people a year in the UK. So, the last webinar on the 22nd, that is the day before yesterday, I was discussing about how to manage the disease with chronic respiratory disease. So, the one particular main thing which I focused was symptom management. In that, if you could remember, if you're a person who will be attending the webinar today. So in the symptom management, the main parts are breathlessness management, which we scientifically call as dyspnea, and cough, deconditioning of the muscles, hypoxemia, end-of-life concerns, and education. So these are the major factors we have to be focusing on the symptom management when it comes to disease management. Today, I'll be more focusing on hypoxemia, which is more related to the breathlessness. So before we could delve into the oxygen and other parts of things, I would like to clear the air between what is hypoxia and hypoxemia. So these two terms are two different terms, and it's very important that we understand between that. And this is also very essential to explain to the patients as well, so that they don't get confused when they get oxygen prescription from their healthcare provider, and at the end of the day, they actually monitor the pulse oximeter and see a different oxygen reading for themselves, because most of the patients have pulse oximeter, to my knowledge. So what we're talking here today is hypoxemia, which is abnormally low arterial oxygen tension, which is called as partial arterial oxygen saturation in the blood. Okay, so this partial pressure of oxygen is measured in millimeters of mercury, which is what that does mean is, like, it is, we discussed about oxygen binding to the red blood cells in the bloodstream in your body, and that affinity has some pressure, and that is what is partial pressure of oxygen. Okay, and same applies to the carbon dioxide as well. Carbon dioxide is a molecule, and it attaches to your blood cells, and the pressure, the affinity of that is partial pressure of carbon dioxide. So I'm not going to go in depth into the scientific terms of PaO2, PCO2 today, but general view about what it is. So anything related to the partial pressure of oxygen inside the blood, the affinity level of your binding capacity of your oxygen to your hemoglobin cells, that is hypoxemia. And if that pressure is low, that is called hypoxemia, sorry. So if that is particularly, you can see in the graph here, there is oxygen saturation and there is partial pressure of oxygen in the x-axis, and there is the O2 content of the whole blood in the y-axis. Yeah, so this is where the alveoli is, and this is where the tissue is at rest. So this particular range here, which actually indicates how much of affinity or the binding capacity that oxygen has to the tissue cells, that is the hemoglobin cells. Okay, so the oxygen capacity is in your healthcare provider is very well aware of how to measure this with the blood gas analysis, which I'll go through in the following slides. But this is how they are actually predicting. They are not guessing numbers. They actually have a crucial, important measurements or blood gas analysis determining that your oxygen prescription. Okay, and the normal ranges of oxygen partial pressure, which I put on this slide, is normal is between 80 to 100 millimeters of mercury. Anyone with a severe hypoxemia is less than 40 millimeters of mercury. As you can see in the graph, at 40 millimeters of mercury, your saturation levels are very low. Okay, it's 60% or 70%, very, very low. And when it comes to 30, below 30, you can, or 28, which is in this figure, and the saturation, which you can measure in the finger pulse oximeter, is 50% of oxygen, and that is too dangerous. So we need to be aware, educating as an healthcare provider, if anyone is watching as an healthcare provider, we need to be very, very crucially educating the patient what is the right level of saturation they should be on. And as I mentioned, the oxygen saturation, which is a non-invasive method, is pulse oximeter, finger pulse oximeter with a finger probe. They assess their oxygen levels. And I would like to introduce another term, is a refractory hypoxemia. Some patients might wonder, like, their oxygen levels are not to the right level of oxygen, even they are using the supplemental oxygen. But your healthcare provider says, yes, you have to be using the oxygen. And that is what we find in your blood gas analysis, and that is what is prescribed. But the patients have a question, why my oxygen is not corrected, even if I'm on the oxygen levels, my oxygen levels are not to the 100%, but it's very low, but my healthcare provider is saying something wrong. No, they are saying right. Some patients might have refractory hypoxemia, which the blood levels of oxygen never increases above certain levels, even with supplemental oxygen. But what your healthcare provider is trying to maintain is a normal saturation, which is essential for the basic functioning of your organs. That's what the supplemental oxygen is provided in few patients. And that's why you'll be finding low oxygen saturation even when you're on a supplemental oxygen, if that explains. So we actually prescribe oxygen, I mentioned earlier, to correct the oxygen saturation. And what is the evidence we base the oxygen prescription? We still rely on the two major evidence conducted 40 years ago nearly, the two studies, major studies. In 1980, there is a NOT study where the nocturnal oxygen therapy trial group, nocturnal means the nighttime oxygen use, they were actually prescribing oxygen for a COPD population with resting hypoxemia. So resting hypoxemia is a low saturation of blood even at rest. So they compared to the moderate group of COPD people, and they found that they did a 5-year trial, and they found the survival rate improved for those people. And in 1981, they prescribed long-term oxygen therapy for 24 hours and a minimum of 15 hours at least, and hypoxic COPD patients with cor pulmonale. So what is cor pulmonale? Is right heart failure. So some people with COPD have right heart failure in conjunction with their respiratory condition. And this study didn't prove the survival benefit, but it still helped them to maintain and improve the quality of life. So these are the two studies we actually base our prescription. And so based on those data and further studies, and those are the main primary studies, we base the oxygen prescription, and further several other studies have been conducted. And there is a guidance on what the benefits of supplemental oxygen is providing us. Its first benefit is survival benefit, which has a good evidence. And secondly, it improves the pulmonary hemodynamics, which is, by that it means that it prevents the pulmonary hypertension. What is pulmonary hypertension? We'll see in the next slide, but it prevents pulmonary hypertension now. And symptomatic relief, breathlessness or fatigue or pain, it relieves immediately. For example, patients with lung cancer have short burst oxygen to relieve the breathlessness. But it is very important that we have to look into the essential, whether they really need oxygen or whether it is symptomatic relief is very needed for the people, even with the saturation high, which is actually in a controversy at the moment when I'm going through the slide. It will be more clearer towards the end whether it is really important to prescribe a palliative oxygen just for breathlessness. So the next benefit is it improves exercise performance, and it improves sleep quality, and it reduces hospitalization. So these are the major benefits of supplemental oxygen. What the guidance say to us, the BTS guidance and the NICE guidance, oxygen corrects hypoxemia, not breathlessness. So if it comes to symptomatic relief, if a patient has breathlessness in combination with hypoxemia, then oxygen should be prescribed. It should not be prescribed just for breathlessness. And oxygen should be prescribed on the needs basis, case by case basis as well. It should not be trialed as a placebo effect. And major tools used for oxygen prescription is the pulse oximeter and 6-minute walk test for the walking oxygen, or the exertional oxygen, what we call as. And for the resting oxygen saturation, main crucial important analysis is the ABG, which is called arterial blood gas analysis. So those are the key measurement tools used to prescribe the oxygen. So I mentioned that I would be explaining you what's pulmonary hypertension. So as you can see in this picture, this is a picture of a normal heart. And you can see this is the right side of the heart here. And you can see the myocardium is in a normal size. If you compare that picture with the second one here, you can see that has been hypertrophied or inflamed or gone bigger, whatever you wanted to call it. So this is because there is increased pressure in the pulmonary vessels, and because the pulmonary vessels have narrowed down, and that increases the work of the heart, right side of the heart particularly, and ends up in right heart failure, which is otherwise called as cor pulmonale. And I mentioned in the earlier slide that we have certain guidance to follow. Why we have to follow certain guidance in prescribing oxygen? Because oxygen is a medical drug, and oxygen should not be prescribed in terms of the symptomatic relief. It should be based on a proper measurement, like for exertional activity, the 6-minute walk test, and the ambulatory oxygen assessment, and also for the resting part of it with the blood gas analysis. And for the indications, if you're a healthcare professional and you're starting up in an oxygen therapy unit, for the guidance of the new guidance, BTS guidelines on home oxygen service 2015 gives a clear indications of for long-term and the ambulatory oxygen. I would direct you to refer there. And in turn, when it comes to the palliative oxygen therapy, again, as I mentioned earlier, breathlessness is not only the main reason you should be prescribing. If the patient has breathlessness, you have to try other means to relieve the breathlessness. If the patient has a combination of breathlessness and hypoxia, the saturation level less than 92%, then they have to receive a trial of palliative oxygen therapy. And some of the tools which we can actually alleviate the breathing, the breathlessness issues for people with lung cancer is fan therapy. People with breathlessness can actually benefit from that with no hypoxemia issues. And the symptomatic improvement should occur within 24 hours, and the functional improvement should occur in the first 3 days of the use. And that's how you indicate that, okay, this person is good for oxygen or not. So these are the measures you can take for palliative oxygen therapy. And for critically ill patients, the examples mostly is the COPD. Major population is COPD patients. So this is based on the COPD population example. So they should receive a levels of oxygen therapy, which is prescribed until the next oxygen therapy prescription has been designed for them. So that means another blood gas analysis or blood testing to establish a range of oxygen therapy for them. The safe range of oxygen therapy, as I mentioned on this slide, 94 to 98% of oxygen therapy for a normal or a type 1 respiratory failure, which type 1 respiratory failure is low oxygen levels. They have no issues with the carbon dioxide levels, but the oxygen level is dropping down. So that is type 1 respiratory failure. So those population is advised to get 94 to 98% of saturation. They should maintain that level. And patients with issues of carbon dioxide, high levels of carbon dioxide, they should actually maintain 88 to 92% of oxygen. And every time a prescription has been done, it should be signed and reviewed by the team, appropriate member of the team, for an appropriate clinical management for the patient. So how oxygen is prescribed in the thing. So we discussed about the pulse oximeter and the blood gas analysis. So I've just given a representation here, how the blood gas analysis, arterial, people who have gone through it will know the pain of it. For people who are not aware of it, this is how it's done. And there is other method as well, low capillary blood sampling. And these two methods are invasive methods to predict your oxygen levels. And the other non-invasive method is for after prescribing your oxygen to maintain and see whether your saturation levels are normal. That is the non-invasive method of pulse oximeter. So an healthy person should maintain an oxygen level 96% to 98 in the daytime. And during your sleep, normally for even healthy people, there is a dip in the oxygen level because when we are sleeping, our airways our trachea getting narrowed down because tracheal muscles are it's cartilaginous muscles, and it relaxes very, very, very easily, and then that gives a dip in the oxygen level, but there is no obstruction in your airway, so your oxygen levels will be bouncing back to normal level very frequently. So during the sleep, less than or equal to 84% of dip is fine, but more than that, and the number of occasions of the dip will be calculated by your healthcare professional if they are providing you a sleep oximeter monitor to measure your oxygen in the nighttime. That's how they prescribe your sleep oxygen as well. And these are the normal levels by the different international bodies. I mentioned 94 to 98% of oxygen for that is a normal or a level type 1 respiratory failure, which is a non-hypercapnic patients. And for other group of patients, non-hypercapnic patients, the Australian group have a different kind of range, 92 to 96% of oxygen level. And for hypercapnic patients, all the three bodies agree that the oxygen level should be maintained between 88 to 92%, and that is the must. And this has a reason behind it. If you're going to give more oxygen, there is a risk of more retention of carbon dioxide, and there is more scientific pathology mechanism behind it, because your oxygen drive will be put to a shut, and more of carbon dioxide will be increased, and you'll be more hyperventilating. So this is actually having a risk if there is an increased oxygen level given to this group of people. So that is very important that people with hypercapnia history should be maintained 88 to 92% of oxygen levels. So now we have to know how the oxygen is prescribed. When a prescription comes, this is a very standard format, and this should also be communicated very clearly to the patient group who are receiving the oxygen. So an oxygen prescription should have the type of oxygen, what type of oxygen they are going to use, and the source of the oxygen, and the method or the mode of the oxygen that's delivered, and the dosage of oxygen. So there are different types of oxygen delivery: long-term oxygen therapy, and ambulatory oxygen therapy, and short burst oxygen therapy, and emergency oxygen therapy. What is long-term oxygen therapy? This is a group of people who have resting oxygen levels low, and they need at least 15 hours of oxygen a day to maintain the normal vital functioning of their body. And the ambulatory oxygen is a group of people who need, resting is fine, and need the prescription for exertional activities like walking or running, whatever the exertional activities that actually means to them. That's where the moving part of it needs oxygen. So that's ambulatory oxygen. And the short burst oxygen therapy is for a group of people where they have an increase, for example, in palliative care, again, which has no evidence, but we have to get rid of short burst oxygen therapy. But some people feel that they are benefiting from short burst oxygen. That's how when they are given the short burst oxygen. And emergency oxygen therapy in case of emergency situations where in terms of surgical or that kind of conditions, they are provided oxygen therapy. So those all should be written clearly in the, when the oxygen is prescribed. And the source is portable oxygen cylinders and concentrator, and both are portable oxygen cylinders and concentrator. There are two forms of it. There is a gas and liquid form. I've not put down the gas here. So there are two types of oxygen sources as well, gas and liquid. And most of the time in Ireland, I found patient groups more keen on using the liquid oxygen because it actually prolongs their oxygen hours, and gas is actually quickly being exhausted. So they prefer the liquid oxygen, and that is also evidenced as well. A liquid oxygen has a longer duration and benefits for the people who are in long-term oxygen. And the method and the mode of oxygen, the face mask and venturi mask, nasal prongs, these are the different ways the oxygen is delivered. And oxygen can be in a continuous or the pulse dose. What does it mean is continuous oxygen is for people with a long-term oxygen therapy, or even for ambulatory oxygen. The oxygen flow is continuously produced during breathing and breathing in and breathing out. Okay, it is constant. And pulse doses, it is produced only, the oxygen is getting into the body only when you're breathing in. So these are two different types where your healthcare provider will be prescribing, and flow rate per minute and the type of activity. So what type of activity oxygen prescribed, either for resting or either for exercise activity or either for sleep. So there are three categories of activity the oxygen prescription is based on. So what's the types of oxygen therapy? We just discussed a list of oxygen therapies, and now we discuss about the hours of oxygen therapy. So long-term oxygen therapy is 15 hours plus more than 15 hours, so 24 hours benefits, but 15 hours at the minimum the patient should be using per day. And the reason, because it improves the survival rate and their sleep, the exercise, the cognitive performance, everything's improved. That's the reason they need that oxygen, because they don't have their own body oxygen sufficient for doing those activities. And the ambulatory oxygen therapy only during the exertional activities. And the short burst activity, the palliation of the for the palliative care, and temporary emergency in terms of the acute episode, which I explained already. And to give you an idea, what are the different types of oxygen sources available? The main providers most commonly are the VOC and the air liquidity, and these are the types of the ambulatory oxygen. People who are using the oxygen might be more familiar with it. And in the hospital setting, you can see the whole outlet of oxygen like this, and the long-term oxygen equipment, the concentrators, the liquid, and the gas concentrator. So these are the available oxygen sources in the oxygen market. And the oxygen delivery skills, as I mentioned already, there are different types of nasal cannulas for each flow rate. As I mentioned, there is also an iFlow uneasy cannula, which is in green. People who are using oxygen will be more aware of it. And there are different colored cannulas. For cannulas, which is oxygen is between 2 to 6 liters. They have white oxygen cannula. So there are different types of oxygen cannula which the healthcare provider will be providing. And also they will be using attachment called venturi mask to make your concentration according to your body's need of oxygen. So there are different colored venturi masks, and there are different levels of oxygen of the venturi mask which links up to. So your healthcare provider will know what to use for you, but it is appropriate that you follow the guidance when you're in the ward. It's mostly used in the hospital settings to keep your oxygen saturations. And the oxygen prescription and documentation, I've just represented here some of the documentation, the model of oxygen prescription documented in the healthcare setting in the hospital. And there are two forms, the manual one and the electronic one here. And as a patient source, a patient needs, they're aware of what is they are using, so that they'll be more kind of aware when there is a panic attack or an episode of hyperventilation and an ambulance arriving and the patient's already on the oxygen. They should have this oxygen alert card with them, so that the ambulance person knows that what level of oxygen the patient should be on before they could reach the hospital. So it might end up in danger if the patient is having a high level of carbon dioxide and the patient is not having an oxygen alert card, and the ambulance person puts on 100% of oxygen on the patient. That ends up in a collapse of your airways and further damage and further complications. So that might be a risky one. So the best practice would be to give an oxygen alert card to the patient. That be helpful for people to avoid further complications. So what are the oxygen safety things? Always oxygen must be prescribed and documented. And using oxygen at home, there should be a sign on the door that the patient is using oxygen. And there should be no smoking board, or a patient should not be in the vicinity of anyone smoking, or people inside the house should not be smoking near a person using an oxygen canister or a concentrator. And the oxygen sources should be 10 feet away from the open flames. And because it's a combustible gas, so there can be an incident of fire hazards, and so it should not be near any of the fires or the flaming products. And also check all the electrical cables in the vicinity of the concentrators. This is one of the safety things we look for when your healthcare provider is sending your oxygen person into your home. They'll come and check everything before they can actually install the oxygen in your home. And it is also your responsibility to keep a regular check on that, so that there is no fire hazards or any other mishap happening. And no oil-based creams, or people who are using oxygen is not advised any oil-based cream because it's an inflammable gas. So any kind of non-oil-based creams or non-petroleum jellies, we should not have any kind of inflammable substances should be used. Water soluble would be the best way to go forward if people have issues of nasal irritation or bleeding when using oxygen. Water soluble creams advised. And transport oxygen cylinders, when you're transporting oxygen, it should be always kept upright and secured with your chain or seat belt when you're moving on from one place to the other in the car or any other way of transport. So it should be always upright and secure. It should not be horizontal or down. And check your oxygen cylinders before planning out, because some people who have a high need of oxygen, they might have the 2 cylinders being ordered in the house, and then they will actually plan an outing which is 40 miles away, and they go in the car and then will be having a lack of oxygen when they are halfway through. So always plan, determine how much distance, how much oxygen you need, and how long your oxygen cylinders last. Okay, each patient is different, so you have to have a record of how the oxygen cylinders are supporting your system of working in your body, and you have to plan the outing accordingly. And the main thing which I've already been emphasizing on is very crucial, that education on the purpose, the prescription, and the follow-up, and the SARS of the oxygen should be well communicated to the patient so that they are well aware of and taking accountability for the oxygen. And some of the SARS of oxygen therapy, as I mentioned here, I've already mentioned about the increased levels of carbon dioxide. So if you're actually, there is another hyperoxemia, opposite of the hypoxemia. So when there is increased level of oxygen levels in your body, there is oxygen narcosis. What it means is there is a collapse of your air sacs if there is even high levels of oxygen, and that ends up in your brain damage as well. So oxygen levels should be measured and prescribed at a level which is required by the patient. And there is also absorption atelectasis. The percentage of gas what we are inhaling has most of part of it is oxygen, and also the other part of the oxygen, other part of the gas is nitrogen. So the nitrogen gas is very essential in our body for the opening of the air sacs. Okay, so the nitrogen gas gets depleted when there is a high level of oxygen going into your lungs, and that leads to atelectasis or collapse of your airways as well. And that's another reason you're not going to let your oxygen level shoot up high than your body needs it. And oxygen hyperventilation is the other issue of the oxygen. If there is a increased levels of oxygen and there is a risk of retinopathy, your retina getting irritated or inflamed, because people using the nasal or the face mask can have the gas leaked into the eyes, and most of this symptom is more prevalent in people with diabetic issues along with their chronic respiratory disease. So the advice would be they should not use any kind of oil-based substances. Some people use petroleum-based things around the nasal pathways, and that also causes irritation, and that causes fire hazard as well. So water-soluble products should be used to the maximum level possible. And for issues of retinopathy, it is very essential that you change, instead of the face mask, the nasal tubes. And there are other forms of products which can actually make a space between your nasal part and the nasal tubing, and you can insert that for your comfort, and that will help you to relieve the excess of gas flowing into your eyes. If it is really a issue, it is best to get checked with the healthcare provider, go back and change the equipment what you're using, and that will be the best idea to avoid that risk of happening. And the dryness of mucosa, increased levels of oxygen is the dry gas. So humidification is a very must, and your healthcare provider will actually recommend devices for humidification if you're using a long-term oxygen. And most of the concentrator comes with a humidifier as well, so that actually gets your oxygen humidified and you're not breathing in just the dry oxygen. And I've already explained about the fire hazard. It's because it's now at this point you'll be very well aware it's a combustible gas and there's a fire hazard. And also falls, oxygen tubing. People with a long-term oxygen in the house, they have the concentrator in one room and the oxygen tubing runs long way. And people with issues with falls or without falls even can have a hazard of tripping over the cables running around the house. So it needs to be tucked in, and to prevent the sorts of falls. And also in terms of the infection, which is more related to the humidification part of it, not to use the bottle humidifier. That is a high risk of infection. So that should be avoided to prevent any kind of spread of infection. So in terms of travel, to touch a bit of it, people with oxygen use, when they are planning a travel, is very, very essential. You plan in advance and be very organized. So at least a month notice needs to be given. The Air Liquid Aid company different companies have different instructions to the healthcare provider. So at least 6 to 8 weeks is the Air Liquid Aid, and at least a month before is the BOC. So you have to inform your healthcare provider so they can assess your blood gases and prescribe your oxygen accordingly. And also you have to be taking accountability, check some of the airways allow only certain kinds of oxygen to be traveled on board in the plane. So you have to be checking with your travel agencies as well, what kind of type of oxygen is allowed in the flight. So those are the pre-planning as a patient you'd be doing if you're a patient. And in terms of the healthcare provider, it's very essential if the patient is actually informing you well in advance, so that a crucial amount of time has been given for the appointments, early appointments, an assessment of their blood gases, and then prescription and communicating with their appropriate provider so that the patient is organized for their travel. And I put 2 links here for further guidance. People who are interested to go on that. It gives them more clear instructions on the travel planning with oxygen. And I would like to clarify some of the myths around the oxygen. And people who actually, there are two groups of people I've come across in my practice previously. One group of people wanted oxygen, okay, and they believe oxygen is really good. If I have more oxygen, I'll be more stronger, okay, and that myth is also not right. And the other group of people feels like, oh my god, I would get addicted to the oxygen, I'm not going to even near the oxygen bottles anytime in my life. So there are two categories of people, okay. We want to have a balance, okay. So we as a healthcare provider are not providing oxygen as a guessing game. We are actually tailoring the oxygen needs based on the assessment of your blood gases, and we are prescribing the oxygen because your body needs it, because we care for you. So I would expect that you actually follow the instruction and not ask for more oxygen or low oxygen, whatever it is. And the other group of people who are actually feeling I'm getting addicted, yes, you will not be getting addicted to the oxygen. The weaning part of the oxygen therapy, I've just explained as here, your healthcare provider will actually be instructing you how frequently, most appropriately it's every 3 months, and the initial prescription is 3 weeks after the initial prescription and then 3 months after. So it is actually your healthcare provider will be assessing your oxygen level. In some people, the oxygen level gets appropriate in their third assessment or full assessment. For some people, it might take years to get right if your body system is actually improving. And so some people might get off the oxygen, and there are some people who have to be staying long term. So it all depends on how your body system adjusts with the oxygen and what are your body needs as well. It also more linked in how your self-management program is. And if you want to really get off the oxygen, just I would advise and request and use this platform as a plea for you who are using oxygen to follow the self-recommendation, like maintaining, optimizing your medication, compiling with your inhalers, and having a good physical activity, having a good diet, and having a good mental health. Those are the factors which will be a product of you coming out of the oxygen or staying in oxygen. That all matters. So it is all relies on it's on the patient part as well. It's not solely responsible on the healthcare provider. So it is a kind of an understanding where we need to focus on more educating the patient as well, so how to manage with the oxygen. And I've talked much about on this slide of addicting, on the myth of the oxygen getting addicted. So I move on to the next myths what people have. Will my shortness of breath go away if I use oxygen? As I already mentioned, oxygen is not a prescription for breathlessness. And breathlessness is multiple factors, it's multifactorial. It's not only lack of oxygen, some people are breathless, it is also muscle deconditioning. It is also your airways getting narrowed. It's also because of the your scarring has happened in the alveoli sac. So those are a lot of factors, multi-factors there. And breathlessness is not mainly related to oxygen levels. Okay, and also some people with anxiety and depression, even without the chronic obstructive pulmonary disease, are breathless. So we can't give oxygen for them. So it is not a product to be provided or prescribed for people with just breathlessness and no issues with their blood oxygen level, if that explains. So it's a big no. And will more liters of oxygen or activity be good? No, again, you are going to cause more damage if you're overusing than the need of your body. So anything more is not good. Anything less is more. Okay, so it is actually what your body needs is a must, and it's a big no again. And will my oxygen bottle or concentrator explode by itself? It will not explode by itself until it comes in contact with any combustible other substances. So you need to be following all the safety precautions as advised by your healthcare provider and the oxygen source provider as well. When they come into installation, they also give you a booklet of instructions what to follow as a safety measure. So you have to follow those things. And as a healthcare provider, we have challenges as well in prescribing oxygen. Yes, we are going to put our best efforts to support you in the prescription, but there are also some political structural issues in terms of timely assessment, the time management around the waiting list. So you might not be getting quicker assessments So we have challenges. We have timely assessment and prescription for the needy patients, and the HOOP form, the home oxygen assessment form, is delayed, and because it has to reach through several other mediators before it can reach the source of the provider. So that causes the delay and frustration from our side as well, that we are not able to support you at the right time. And also in terms of the oxygen alert sticker, it's not provided to many of the places around the UK even. Only some group of people or some places have this as a policy, some places don't have this policy. So that's another challenge we have. And emergency oxygen is not prescribed, it's just been administered and not documented. That's another thing where we cannot follow up on it. And there's a lack of sufficient oxygen assessment and review clinics in the primary and the secondary care. And also there is inconsistency in the sources of in the resources, like the human resources, the staffing, the training levels, and updating the best practices. And we also have missing a comprehensive database in our systems. There should be a cultural change overall in terms of the oxygen database maintaining. And there is also shortfalls in local service promotion on the oxygen therapy. And from my experience, both in Dublin and in northwest of England, when I initially talk about oxygen, it is actually a shock for one group of people, and we totally understand that. And the other group of people are more willing to have the oxygen, and both group of people actually lack, even though they have these kind of responses, they lack the knowledge of oxygen. So it is crucial that oxygen needs and services should be providing more education to the consumers as well. And the take-home message here is demand education from your healthcare provider on the oxygen therapy. Know your oxygen prescription at rest, exercise, and sleep, and follow the recommended steps what your healthcare provider recommends, because we care for you. And plan in advance for your travel. It is very, very crucial. Please don't come in the last 2 weeks of your flight being booked already and come to us in 2 weeks' time and say that you're flying in 2 weeks. Please don't do that. So it needs a lot of procedures to be followed. And bring your oxygen for the pulmonary rehab clinic, which is very, very essential. So thank you again for listening, and successfully passed over this second webinar today. And I thank for all your support and contribution, especially the mentoring. Any questions or comments and thoughts, please do put on to the YouTube channel or to my email, which is mentioned here directly, the lungrehabvoyage21@gmail.com. Or we have also had the Twitter page now at rehablong. And I will also try my best to answer your questions and make my best possible efforts to be supportive on that role. And I would see you on the next webinar on the 25th of June. Mind your health, mind your mental health. Thank you for listening.
Gemma, do you have any queries? Okay. Thank you, Devi. That was wonderful and much needed knowledge.
Thank you very much. And thank you for the support.
Shakila,
explained it clearly.
Thank you.
I have got technical issues, so I just turned off. So I think you should. Thank you, Gemma, for joining us.
Okay, so no problem.
Bye-bye.